The mouth occupies the largest room in the face. If you open the mouth, you can even look all the way back into the throat. So this lecture is about the anatomy of the mouth. Yes, the topic of this lecture is the mouth, or more precisely, of course, the anatomy of the mouth. As topics, or learning objectives, if you will, we will first discuss the anatomy of the perioral muscles. In a rough overview, we have already seen this in a discussion of the anatomy of the face, but now we will go into more detail. The same goes for the innervation and for the blood supply. The pictures do indicate this already. We are of course also looking inside the mouth. There are a lot of good textbooks on this topic, and ultimately you can find all the content I address in this lecture, of course, all the pictures and words in our atlas, The Face, and in my textbook Oral Structure and Biology, which is why I always include the page numbers in the top left-hand corner. Looking from the surface, the lips are special to the mouth. The upper lip and the lower lip, and also the entrance of the mouth. When the lips are closed, then we can only see a small gap, the rima oris. On the upper lip, the philtrum and the cupido arc are characteristic. Cupid, of course, is Latin and means lust or desire. The arch on the upper lip is also called Cupid's arch. Cupid is the son of love. So this is the arc-shaped border line of the upper lips read against the philtrum under the tip of the nose. Because the lip is an erogenous zone, it was obvious in ancient times to establish a connection here to love or even to desire. And now philtrum is ancient Greek and can be translated as love charm. So the philtrum is made up by the two vertical lines in the upper lip that run from the nose to the red of the lips. It is amazing what has been interpreted into the upper lip. To the side, there is the angle of the mouth, and from the outside, the oral cavity is closed by the cheeks. When we laugh, we create this marked nasolabial fold. A layer of fat is initially found under the skin in the perioral region. This can be quite thin in places in the lower lip region. Let us take a look at each muscle in detail in this impressive image, which shows all the muscles of the perioral region. First, there is the orbicularis oris muscle. This is a rather strongly developed muscle that runs in a circle around the mouth opening within the upper and the lower lip. It is ring-shaped, and its fibers, of course, cannot exactly be seen now because several muscles still radiate obliquely into the lips from the periphery. Of course, we will discuss them now also, and then we will take them away layer by layer again in order to get further into the depth. So first, there is the levator labii superius muscle, which originates on the maxillary bone under the orbit and passes laterally past the nose into the lateral portion of the upper lip. The levator labii superioris aliquinensi muscle comes from the very top, actually originating at the top of the forehead and extending further medially into the upper lip. And it makes sense. When this long muscle contracts, it can pull the upper lip upwards. And as the name implies, if its muscle fibers also make contact to the nostrils, it can also pull those up with it. Now we go a little further into the lateral region, and here the zygomaticus minor muscle runs. It comes from the zygomatic arch and pulls on the upper lip. A little further laterally, the zygomaticus major muscle has a similar course. This muscle is slightly larger and attaches more laterally in the upper lip, more at the corner of the mouth. These two muscles, the zygomaticus minor and the zygomaticus major, they run somewhat obliquely. And here in the depth we can see a part of the levator anguli oris muscle, but we will get into this deeper layer in more detail later. Let us stay in the most superficial layer of the muscles. Here, the risorius muscle runs fairly horizontally. It also pulls into the corner of the mouth somewhat more caudally from the zygomaticus major muscle. This muscle originates from the fascia of the masseter muscle. And all three of these superficial muscles, this risorius and the two zygomatical muscles, they pull the lip and the corner of the mouth backwards. They are therefore active during laughter, and that's why the risorius is called like this. In here in the lower cheek area you can see a part of the platysma. This is a very flat muscle that runs across the neck and extends somewhat across the cheek into the face. This is also one of the muscles of facial expression. And further forward on the face, at the corner of the mouth, lies the depressor anguli oris muscle, which, due to its course from the edge of the lower jaw to the corner of the mouth, can pull down the corner of the mouth. And further medially and partially covered is the depressor labii inferioris, which has an oblique course and further medial to the mouth. And what it does, it's clear, it pulls the lower lip down. In the middle, the mentalis muscle. It runs from the bony chin to the skin under the soft tissue skin. When it contracts, there is a cobblestone-like pattern on the chin. And here is the buccinator muscle. It comes from behind, from the pharyngeal wall, from the pterygomandibular raphe, and then it runs alongside the teeth to the front, where its fibers meet those of the orbicularis oris muscle. We can also consider the orbicularis oris and buccinator functionally together as one muscular loop that bounds the mouth from the outside. Of course, there is this horizontal slit in front, the mouth opening. At the very least, this muscular loop as a whole exerts forces that can act on the tooth position, or in other words, the space between the tongue and the cheek and the lips. That's the space where the teeth are allowed to stay. And these aforementioned muscles ultimately determine the shape of the dental arch. All the muscles that we have discussed up to this point, these are all muscles of facial expression, and they are innervated by the facial nerve. We had already addressed the blood supply to the face in some detail in the lecture about facial anatomy. Here in the mouth region, we only need to remember the facial artery, which comes from the external carotid artery and runs diagonally across the face, past the nose. But at the nose, it has a different name. There it is called angular artery. From this facial artery, several branches turn off medially. First, there is the submental artery, which branches into many small sub-branches in the chin region. In addition, there is the mental artery that comes out of the mental foramen, which is an extension of the inferior alveolar artery that passes through the canal in the mandible. And here too, there are many anastomoses of the small vascular branches. Branches that turn off directly from the facial artery are the inferior labial artery to the lower lip and the superior labial artery to the upper lip. And posteriorly, there is also the transverse facial artery, which comes from the superficial temporal artery. Then there are the posterior and the anterior mesenteric arteries in the region. But they come, before they split, from the mesenteric artery, which crosses over the mandibular notch. That is the curve between the condylar process and the coronar process. And ultimately, it comes from the maxillary artery. And then there is a small zygomaticofacial foramen on the zygomatic bone, from which the zygomaticofacial artery comes out, together with its nerve and vein of the same name. Sometimes it's double, and sometimes it may be completely absent. And under the eye, there is the infraorbital foramen, and that is never missing. It is the continuation of the infraorbital canal, and this is where the infraorbital artery comes out. Its branches divided a lot, and then there are also many anastomoses with all sorts of small arterial branches in the region. The venous outflow from the oral region works similarly, only the other way around. We find on the right side in the picture first the smaller branches, the zygomaticofacial vein, the transversal facial vein, and the veins from the masseter muscle, and the small ones from the upper lip. And below the eye there is the infraorbital vein, which carries the venous blood into the infraorbital canal. And in addition there is the inferior labial vein, the submental vein, and the mental branch, which is so small that it probably does not deserve the name vein for itself. So it is only called branch, and it pulls into the inferior alveolar vein and thus into the inferior alveolar canal. And to conclude this chapter on the blood supply, of course the angular vein next to the nose, which then continues obliquely across the face as the facial vein, just like arteries of the same name from earlier. Its venous blood is delivered into the internal jugular vein. The nerve for the motor innervation of the muscles of facial expression is the facial nerve, the seventh cranial nerve. It emerges from the stylomastoid foramen and, as the name suggests, between the mastoid and the styloid processes. It then spreads out across the face to reach every facial muscle that belongs to its field of innervation. Many of the nerves are then actually called branch or branches, such as the zygomatic branches or the buccal branches or the marginal mandibular branch or the cervical branch. Now, of course, we have to be careful not to confuse the innervation from the facial nerve with that of the trigeminal nerve. The mental nerve here is a branch that comes out of the mental foramen, which is a continuation of the inferior alveolar nerve and thus from the trigeminal nerve. And also the infraorbital nerve belongs to the trigeminal nerve. This nerve gives off the branch to the lower eyelid, the palpable branch. You have to be careful not to get confused. The best thing is to do is to sit down with a good textbook and write down all the muscles of the perioral region or the facial region with their respective innervations. Then you have to learn that. This would be a bit too boring for a lecture. And one more hint. It is said that the muscles of facial expression are innervated from the facial nerve because the facial nerve is the nerve of the second visceral arch. This lies, of course, further caudally than the first visceral arch. And the nerve of the first visceral arch is the trigeminal nerve, the fifth cranial nerve. But the nerve of the second visceral arch is the facial nerve, which innervates the muscles of the surface of the face. And because this cranial nerve is located somewhat further caudally, it is concluded from an evolutionary biological point of view that the muscles of facial expression must have migrated from caudal into the facial area during the historical course of transition of species, together with the associated motor nerve. This may seem conclusive from an evolutionary biological point of view, if one assumes that the lower species have no muscles of facial expressions and expressive ability, and the higher species have more and more. So if you look at crocodiles, snakes, or turtles, and in comparison to at hamsters, dogs, horses, and then monkeys and humans, they always have more abilities of facial expression. But during embryonic development, we do not see any muscle migrating from the second visceral arch up into the face. It is different. the myogenic cells migrate, as far as we know, from the back, from the neural crest into the facial region, and then they become real muscles there and acquire their fiber directions. How that works, we will see in the embryology lecture, and then they are reached by the nerves. So, the evolutionary history is not repeated again in the embryo. And in this picture, we see again all arteries, veins and nerves all together. And don't get frightened, but rather remain confident that one day you will be able to untangle and describe all this. That's what you are studying so thoroughly for. Up to this point, we have discussed the muscles, the blood supply, and the nerves separately. In this section, we will look at the topographical relationships in their context. So, what we are doing now is really topographical anatomy of the oral region. Of course, you already know most of this now, but we are going to look at its context now. So here, the buccinator muscle, on both sides of the dental arches, with its sagittal course through the cheeks. And what you see here also is on the right side of the patient, so on the left side on the image, we have drawn in the blood vessels, and on the left side, the nerves. So the infraorbital artery comes out of the infraorbital foramen, and the infraorbital vein is pulling in there. And of course, the infraorbital nerve, for the sake of clarity, is shown on the other side. At the small zygomedicofacial foramen, we see the passage of the zygomedicofacial artery and vein and the zygomedicofacial nerve. At the mental foramen, the mental artery and vein and the mental nerve. At the edge of the mandible, the facial artery and vein come around here, and then, they go obliquely across the face, past the nose, where they change their names. So now we go one layer up. Now we see the course of the facial artery and the vein on the cheek, and the masseter muscle as it covers the posterior part of the buccinator. Here we have the well-known orbicularis oris muscle again, which runs within the upper and the lower lips, and the chin, the mental muscle. And when you look at the right image more closely, you will see that Karl Wesker has already drawn a somewhat longer course of the vessels and for the nerves. Now let us put some more muscles on it, so let's go one layer higher. Now here we have the levator anguli oris muscle covered by the blood vessels and the nerves that you now already know. And the depressor labii inferioris, of course, also now with its blood vessels and nerve supply. On the right side of the image, we are now one layer higher, and we can see the angular artery and vein, and underneath the levator labii superioris, and below the mouth, the depressor anguli oris muscle. And between the depressor anguli oris muscle and the masseter here, there is emerging the buccal nerve. This is a trigeminal branch which is sensory and supplies the mucosa of the cheeks and the gums. But in addition, it also has parasympathetic fibers, so it reaches the salivary glands in the buccal mucosa and controls their activity also. So you see lots of little details that are all important in some way. And these small nerve branches, these are the marginal mandibular branches from the facial nerve, which of course then provide motor supply to the facial muscles in this region. Now we put another layer on top of that, and we now see the minor zygomatic muscle, and next to it the zygomedicus major muscle and the risorius, the muscle we use for smiling. In here again the platysma, another muscle of facial expression. Innervation provided by the facial nerve. You already know the picture on the right with all the perioral muscles, and in the picture on the left you can see the lips and the tongue in a sagittal section, plus the teeth, which fill exactly the space kept free from them by the lips and the tongue. As soon as the teeth emerge into the oral cavity, they are subject to the forces exerted on them by the tongue and by the lip and the cheeks. In the posterior region, it is in a similar way, of course, the cheek muscles, as I said, which do the same. In any case, you must pay attention to the patient to see whether the balance between the tongue function and the muscles is given. If not, this can be one of the many causes of tooth malalignment. And one more hint. The tip of the tongue should actually be a little higher up on the palate. This is what Dr. Codoni, the speech therapist in Basel, with whom I have worked a lot, told me. This picture, like most of the pictures in this atlas, was taken from MRI scans of my daughter Jana. I had said that before in the facial anatomy chapter. The tip of the tongue is now resting against the teeth, but it should be further up against the palate. I have explained that to Jana already, and she will pay more attention to it in the future. Now let us take a look inside the oral cavity as well. To do this, we first must familiarize ourselves with a special nomenclature in the mouth. For orientation, we divide the mouth into 4 quadrants, which we number as upper right 1, upper left 2, lower left 3, and then the lower right is the 4th quadrant. Then we see the teeth, and in relation to the teeth we can speak of vestibular and oral. Here we will distinguish. In the lower jaw, oral is lingual, and in the upper jaw, oral is then palatal. This would actually not be necessary because also in the upper jaw the tongue lies palatally against the teeth. In English, this is not so clearly differentiated. There is often the situation called lingual, even when we are in the upper jaw, which is of course okay. Along the dental arch, we distinguish between mesial and distal. And here we have to pay attention. These are terms from dentistry. The rearmost teeth are away from the dentist, so they call them distal. Generally speaking, they are closer to the center of the body, which is why biologists tend to refer them as proximal and the incisors as distal teeth. This is often the case in non-medical literature, for example, when talking about the teeth of mice. There, the molars are the proximal teeth and the incisors the distal teeth. They are sitting at the end of that long snout. That's how we have to understand it, like the fingers on the hand. The fingertips are the most distal end of the arm. But in dentistry, the distal end of the dental arch is the rearmost end at the molars, and the opposite direction towards the incisors is called mesial. But not only the sides that point to the center in the central incisors, that would even really also be called medial, but also the front of a molar, further back in the dental arch, would be its mesial side. Well, then we still distinguish lateral and medial, whereby it is then more precisely called buccal in the direction of the cheek. And now we have everything together, and you will have learned that quickly. Let us take a quick look at the names of the anatomical details in the mouth. These are the frenula. There is one frenulum on the upper lip and one on the lower lip. Then the hard palate is called the palatum durum, and the soft palate at the back is called the palatum molle. The rearmost end of the soft palate is the uvula, which is attached to the soft palate, the velum of the palate. People are very sensitive here. That's the place. You must not touch it. It immediately makes you vomit. It is also very practical. Good. And then the back of the tongue, the dorsum linguae. Here is an intraoral photograph of the mouth. We see the upper lip with the frenulum in the middle, which is made out of fibrous connective tissue, and there are several more of these towards the cheek, and then they are called the frenulum of the cheek. Or other names are lip furrow band and cheek furrow band. As further structures, we can see the cheek itself and of course the teeth, which are not labeled. The teeth are partially covered by the gum, which has its margin at the transition from the crown to the root of the tooth. At the gums, we see the attached gingiva in lighter pink, and in dark red, we see the oral mucosa. Here you can see the blood vessels are shining through better. Details to the structure and histology of these mentioned parts will be addressed in the appropriate further lectures. Here is another diagram. We will not go through each individual tooth in this lecture. For that, I again recommend that you rather read through it yourself at your leisure. But before that, I would like to clear up some confusion about the numbering of the teeth. You see, I have drawn here the dental arches of the deciduous teeth on the left and the permanent teeth in the right diagram. Upper jaw on top, lower jaw at the bottom, and then the 4 quadrants as explained before. I have highlighted in pink the tooth numbering as used in most of the world today, according to the Fédération Internationale Dentaire, FDI. There you start counting in the middle, so the incisors are number 1, and then you go backwards from there distally to the 5th in the primary dentition and to the 8th tooth in the permanent dentition. This is basically the same in every quadrant. But of course, you still want to know exactly which tooth it is, so you put the number for the quadrant in front of it. So first, look at the permanent dentition, the right diagram. There, the upper central incisor is in the first quadrant is labeled 1, 1, and the upper central incisor in the second quadrant is labeled 2, 1. This is how it continues for each tooth, actually very clear. In order to distinguish the teeth of the primary dentition from those of the permanent dentition by their numbering alone, the numbers 5, 6, 7, and 8 are used here for the quadrants. So it is 5, 1 for the upper right central incisor. And actually quite clear and very well suited for fluent writing on the personal computer. But here are a number of other numbering systems for the same tooth, which is also currently in use. In biology, and this is then of course also concerns the current basic scientific studies on the masticatory system. In other words, in biology, the teeth are usually designated by letters. I for incisor, C for canines, and M for molars. And in the milk dentition, they use lowercase letters, that's obvious. And in the permanent dentition, the appropriate capital letters are used. And there are premolars, which get a capital P, or BC for bicuspid. In the US, the teeth are still numbered differently in dentistry. The milk teeth are identified with capital letters, and they don't start to count with the incisors in the middle, but with the upper right last tooth in the back. Thus, the second milk molar in the upper jaw on the right is identified with the letter A, and from there it goes mesially, then to the other side of the dental arch, and then down to the back left, and from there into the opposite direction until the second milk molar in the lower jaw on the right is then described as T. So I have to say it took a while for me to internalize that when I worked there and imagine a specific tooth with corresponding letters. And in the permanent dentition, it is done in the US in a similar way, but with numbers. Here you simply count all the teeth, but you also start at the top right-hand corner in the back. So the wisdom tooth on the upper right has the number 1, and the upper right central incisor has the number 8. And so it goes on to the back left to the wisdom tooth on the upper left with the number 16, down to 17, which is the wisdom tooth on the lower left, and then along the lower dental arch over to the other side, where the wisdom tooth on the lower right has the number 32. So this is where you get confused very quickly. Tooth 1, in Europe is the upper right permanent incisor, and the same tooth is called tooth number 8 in the United States. So here you have to pay close attention when it says one way or the other way in textbooks, or when you see doctors' letters going back and forth between the US and the rest of the world. And then there is the Zsigmondy system. Whether that's still in use, I don't know, but I remember seeing it when I was a kid, when the school dentist came. The teeth were marked on the paper files with ballpoint pens with the numbers 1 to 8, but the quadrants were marked with such crosshair-like lines. And this is what actually was quite clear, but somehow not possible with the digital record keeping. By the way, the milk teeth had Roman numbers to distinguish them. But as I said, today that's no longer in use. So now let's take a closer look at the lips, the teeth, and the oral mucosa. Now here is the red of the lips. Why are the lips so red? The blood vessels are shining through. There is not much of any other tissue between the surface and the blood vessels. Details will be provided in the video about the oral mucosa. And here is the transition to the oral mucosa region. And here we are in the fold between the lips and the alveolar process. This is the oral vestibule. It continues into distal direction all along the cheeks. And just for the sake of the order, teeth are also in this picture. As an example, the incisor, but I didn't label them. So macroscopically, the whole oral cavity is lined by the oral mucosa. The transition is the area of the lip with the arrow in the picture earlier. I will devote another full lecture on the oral mucosa. There's a lot of detail to talk about, especially on the histological level. But macroscopically, we have to talk quite a bit about the lips here. So at first, the skin of the face, which is of course also a part of the lips. Then the red zone of the lips, and opposite of the teeth there is the oral mucosa of the lip. And there are very many of these small salivary glands, each with its own little excretory duct. And a bit under the skin surface of the face, we typically find the sweat glands, the sebaceous glands, hair, and within the lips there are these orbicularis oris muscles. Here now in the sagittal section, and here again one of the many single salivary glands. Of course, in my lectures there are special videos devoted on the components of the teeth, also about the periodontal tissue, the periodontal ligament, and about cementum on the root. But here we can start to get a first insight into this special region. So when we enlarge this, then we see in the rightmost image how the gingiva just reaches the crown of the tooth and even covers the enamel coating to a certain extent. It is not really fixed to the tooth, but rather attached by adhesive forces only. This is a very sensitive area, which of course will be discussed in detail in further videos. In the circle drawn in, we then see a thin layer of cementum on the root of the tooth, shown in yellow. And from there, many small thin fibers go out across the periodontal space to the alveolar process bone. Those are the periodontal fibers that anchor the tooth in its bony compartment. And if you have also been staring all the time at this canal in the root of the tooth that goes from the pulp to the periodontal space, I can say there are thousands of those canals in the root of the tooth. This is a quite normal condition, and that way the connective tissue of the pulp is in communication with the tissue of the periodontal space. This, of course, has a clinical significance. Inflammatory mediators can migrate in both directions, and as a patient you can notice that in a certain way. Now there are some peculiarities on the palate we need to talk about. If you move the tip of your tongue to the palate, you will feel these transverse waves, the palatine rugae. This is where the tongue normally is supposed to rest, so try it out. What we see here in the picture is the region of the hard palate, although that also has some softer areas. Here in the right image, where the palatal mucosa is partially removed, the arrow points to the many salivary glands, the very small ones, of the palate that are present in the mucosa. There is also some fat here. So the so-called hard palate has also some softer zones. Further details on this will be addressed in the lecture on the oral mucosa again. The palatine artery runs here along the margin. Here you have to be careful not to injure it. Well, it can bleed quite a lot because it is as thick as a pencil lead. Anyone who performs surgical procedures knows that. Of course, there is also the corresponding vein, but we have not drawn it in here. But here, there is also the palatine nerve. You must not injure that either. In the lower jaw, there are also some clinically important details. At first, the oral mucosa itself. It is very thin here. This means soluble medication, such as nitrolingual spray, for example, and against angina pectoris, are absorbed very quickly. The mucosa is very thin, the veins are quickly reached, and from there it is not far to the heart. At the margin, there is the sublingual gland, which shares a common excretory duct with the submandibular gland. And however, we cannot see the submandibular gland in this picture now. The sublingual artery arises from the lodge between the geniohyoid muscle and the sublingual gland, and also the hypoglossal nerve, the 12th cranial nerve, comes in here from the side and from behind and moves into the tongue, which it innervates motorically. In the very front, in pairs on both sides of the lingual frenum, the excretory duct of the sublingual gland, the sublingual caruncula, opens on both sides. Now we also have to look how the floor of the mouth is made up by its muscles. We look from dorsal to the mandible, the hyoid bone is also included. And from there the hyoglossus muscle originates, which pulls into the tongue. Although we do not see the tongue here, of course it's been removed. And in the middle, the parageniohyoid muscle runs from the chin to the hyoid bone. And under this muscle, which is running in sagittal direction, the mylohyoid muscle stretches out with its fibers running transversely. It is drooping like a hammock. And in the right picture, there is now a lot more to see. First, above the geniohyoid muscle, the genioglossal muscle is running in the same direction, but as the name is saying, it then pulls upward into the tongue. We have already seen the sublingual gland earlier, and now we also see the submandibular gland, how it is attached to the posterior edge of the mylohyoid muscle and how it is also partly resting on the muscle from behind. From here, the submandibular duct goes to the front, where it is also receiving individual additional small excretory ducts from the sublingual gland. And from the side, it is also interesting. Here we see the digestic muscle below the mylohyoid. Its anterior belly also comes from the chin and runs in the direction of the hyoid bone. However, it does not insert here. Instead, it is redirected by this sort of a deflecting loop. And from there, this two-bellied muscles runs with its posterior belly to the mastoid process, more precisely to the mastoid incision of the temporal bone. In front of it lies the styloid muscle, which surrounds the styloid process and pulls toward the hyoid bone. And starting from the hyoid bone, the infrahyoid muscles pull downwards. They are located in front of the larynx and reach all the way down to the sternum. But one of them, the omohyoid muscle, bends backwards and even reaches the scapula. Anyway, all the muscles working together can stabilize the hyoid bone in its position, which helps during mouth opening. And also, all the muscles that we see here are active in the act of swallowing. We will look at this toward the end. They have a special video on the act of swallowing. But first, a clinical note on a typical dental anesthesia. This block anesthesia, this block of nerve conduction, is very often used for dental treatments in the lower jaw, and of course also for periodontal surgery and similar procedures, for example, removal of wisdom teeth. In doing so, the inferior alveolar nerve should be anesthetized at the point before it enters the mandible from lingual into its canal. You can see it better in a dorsal view. So in the circle, you see the alveolar inferior nerve just before it enters the canal and disappears in the mandible. And medial to it is the lingual nerve. You should avoid to hit it directly, but you cannot prevent the anesthetic depot that you injected there into the connective tissue also from diffusing into the lingual nerve, and then the tongue also becomes numb. You have to be careful that the patient does not bite his tongue until the sensory innervation is restored after treatment. So if the nerve block at the inferior alveolar nerve is well positioned, then the whole distribution area is well anesthetized from that point on. So all teeth of the side, as well as the gums and also the chin in the region of the mental foramen and also the lower lip, because the nerves also pull up to there. A share of the lower lip may even be anesthetized over the middle on the other side, depending on how the innervation is individually developed here. And here we can have the topographic context in a sagittal section, just a bit off-center. In the nasal region you can see the nasal septum, and then the palate, to a great extent bony, but at the very back the soft palate consists only of a rough tendon plate and muscles inside. And when swallowing, the soft palate folds up and closes the nasopharynx. The tongue, as you can see here, is quite voluminous and completely filling the oral cavity. And downward, the oral cavity is bounded by the muscles of the floor of the mouth, we have already discussed. And dorsal of the soft palate there is the nasopharynx, and we see the opening of the eustachian tube, which is a canal that extends all the way to the tympanic cavity of the middle ear. This can be used to equalize pressure all the way to the eardrum, if that is needed. If you hold your nose and gently build up pressure with your mouth closed, you should be able to feel or to hear all the way at the eardrum. That way, you have just made the Valsalva pressure equalization test. And further caudally, we have the larynx with the epiglottis open here. And when we swallow, the larynx is elevated and the epiglottis is closed and the airway thus blocked. And the esophagus takes over. Finally, we can see here a small film about the act of swallowing. This is a very old film, and here during the swallowing of a radio-opaque food bolus, an X-ray movie sequence was made. When you swallow, the teeth of the upper and the lower arch come together, and the back of the tongue makes a peristaltic movement towards the esophagus. This oral phase of swallowing is followed by a pharyngeal phase, when pharyngeal muscles contract from top to bottom, and the act of swallowing is a complex reflex-controlled process. Now we are done, and we can now come to the take-home message. We have discussed the anatomy of the perioral muscles in detail, also their innervation and blood supply. And in a second run-through, we reviewed everything together, as there are muscles, blood vessels and nerves in their spatial arrangement. And finally, we reviewed the localization of the anesthetic block of the inferior alveolar nerve. And at the very end, the swallowing act. And with that, I thank you for your kind attention.